All right. So, without further ado, our next speaker is Bruce Tromberg. Bruce serves as the director of the National Institute of Biomedical Imaging and Bioengineering at NIH. And in his role, Dr. Tromberg oversees research programs focused on developing, translating, and commercializing engineering, physical science, and computational technologies in biology and medicine. And this includes the Rapid Acceleration of Diagnostic Technology initiative, which I'll turn it over to him to tell you more about.
Thank you, Nate, and thanks to the coalition for putting this on. It's a really wonderful opportunity. Nate asked me to give a little background on how all these kinds of programs that we're using got started. So I'll go into RADx tech, where it all came from, and how it couples into the Hep C initiative. Next slide, please. So this goes back to the heart of the pandemic in April of 2020, when Senator Alexander and Senator Blunt actually reached out to Dr. Collins, saying, we're not sure there's enough investment and capacity for diagnostics for COVID, and we're really interested in understanding what NIH is doing about this. And Dr. Collins was really well aware of initiatives that we at NIBIB had initiated in order to really go beyond laboratory testing and try to dramatically expand test platform type and performance so they could reach people in their homes or at the point of care. So this led to a conversation between Dr. Collins. He called me into the phone call. I explained a little bit about what our plans were to create a competitive innovation funnel type of approach that we could get innovators from all around the world to submit ideas and have a systematic way of evaluating them in what we called an innovation funnel. Senator Alexander wasn't quite understanding that well what I was talking about. And Francis said, it's like a Shark Tank. And they immediately really grasped the concept, I suppose because of its popularity in sort of popular media circles, but it really kind of stuck. And just a few days after our conversation, we saw this editorial piece in the Washington Post by Senators Alexander and Blunt. We need more COVID tests, and we propose a Shark Tank to get us there. And that really helped drive and popularize the underlying idea behind what we were trying to do. We didn't know at the time, this was in sort of mid-April, the conversation, but on April 24th of 2020, there was a fourth congressional supplement, which included $1.5 billion in it to NIH for advancing testing platforms and technologies and actually distributing them to underserved and underrepresented populations all around the country. So that was the birth of the RADx programs, the tech and the UP, the RADx underserved population programs. And our goal at the time was to try and expand point of care and over-the-counter testing in a very ambitious way so it would exceed ultimately laboratory testing. And we needed tens of millions of tests to be produced by fall of 2020, as articulated by these leaders. So we used this innovation funnel approach, and next slide, please. And we couldn't just launch a complete initiative from nothing. So we were able to build on a very well-established network that we at NIBIB had invested in, the Point of Care Technology Research Network, or POCTERN. And that involves a consortium of academic sites and industry, Johns Hopkins, UMass, Northwestern, Georgia Tech, Emory, CIMMYT, the Innovation Center at Mass General Hospital. And we added unique structures to this network so they could validate new technologies and ideas as they came across the transom. That was a validation core at Emory, Georgia Tech, a clinical studies core using standard design and digital health platforms, single IRB center network types of approaches so that we could evaluate test performance very quickly, as well as a deployment core dealing with supply chain, manufacturing, building user communities. And our primary vehicle for all of this consortium, which added many members of government, academia, and industry, swelling to nearly 1,000 participants early in the pandemic, was the innovation funnel, or the Shark Tank, where we received over 1,000 applications to come in over 3 different openings of that innovation funnel. Next slide, please. Well, at the beginning, I kind of thought this was a technical problem for us to solve. All we had to do was bring out all this wonderful innovation in technology and science and get them developed, and it would find its way to the public. But of course, there are many cultural and administrative and organizational hurdles to overcome. So the RADx program spawned off several other elements to the program, including RADx Mars, which is a digital health platform that allows mobile devices to be used for online fulfillment and delivery of tests to people's homes. We launched a program called Say Yes COVID Test that evaluated the idea of people testing in their homes in the first place. It had never really been done at scale. The largest scale had been in pregnancy tests, which is about 8 million a year. In February of 2022, we saw 1 billion tests being distributed to people in their homes. So we needed a major paradigm shift and need to evaluate whether or not this could occur. We launched a variant task force to deal with testing performance in the presence of rapidly changing variants. The really quite well known now, the ITAP program, the Independent Test Assessment Program, which deepened our relationship with FDA and allowed us to move through authorization at an unprecedented speed, which directly impacted the Hep C project, home test to treat programs, redesign of tests for more accessible. So we launched all of these after that initial innovation funnel to solve many of the other problems, and we continue to maintain these structures. Next slide. So what's the bottom line impact? In terms of what our investments did for increasing test capacity over a 3-year period between April 2020 and April 2023, test capacity we were able to increase by about 8 billion tests, 56 EUAs, 15 or actually a few more than that, multiplex COVID flu tests, including a recent de novo one that now has been authorized, and help drive this paradigm shift out of laboratories and into over-the-counter and point-of-care tests, which, next slide, please, have been driven through this incredible cooperation between government, industry, academia, all coming together around this ITAP process. So the FDA was incredibly enthusiastic about the potential for ITAP from the very top, from Jeff Shuren, the center director, the entire OHT7 team, the technical team, fully on board in helping us work with them to optimize workflows and improve accuracy, precision, and performance of tests as they came about. I won't go into details on this, but I think the really big feature to it is compressing the timeline through economization of multiple steps all along the way, ensuring that data are acquired independently. And Eric, Lai, and Pam perhaps may be able to comment on some of the details of that just after my talk. An important feature of this is we were able to provide the FDA with really large-scale quantitative evidence that helped inspire changes of FDA policy. One notable example is the idea of serial testing, which they embraced very strongly with the evidence that we were able to provide from these kinds of studies. Next slide. So what's next for RADx Tech? You've heard hopes for Hep B, which is an ongoing project. So in infectious disease, we've expanded, had the Hep C successes, but are also working hard to do STIs, HIV viral loads at point of care in regions where they are accessible, and have many different budding collaborations in infectious disease with lots of partners. So we've reached out. It's not any longer just a COVID-driven phenomenon. We form partnerships with multiple stakeholders across the NIH and other government agencies to try to advance and accelerate urgent needs, both in infectious disease as well as chronic disease and prevention. And we note neurotechnologies, maternal health technologies, fetal monitoring, endometriosis detection. These are all being done using the basic RADx framework of acceleration, working with regulatory and de-risking technologies so they really can find a truth application very, very quickly and move out to the public. Next slide. So to summarize, we've seen this experience driven by the pandemic, where consumers and people at home and the point of care are really a new diagnostic market at a scale that was really unanticipated and unprecedented prior to the pandemic. The opportunities here are to continue to keep this active so we can leverage a lot of these advances to be pandemic ready. We built digital health infrastructure, diagnostic technology infrastructure, and they need to be continued to be invested in for other challenges and problems. How do we get this into medicine is a next big challenge. Integration into healthcare, electronic health records, reimbursement, connecting the testing with sustainable economic systems. And then ultimately, this big driver of telehealth and telemedicine, which is looking at patients across a screen, but could benefit dramatically from technologies that could be easily deployed in people's homes and at their point of care to optimize clinical decision making, would be a wonderful coming together, illustrating the power of this approach. So with that, I'll finish.